Good afternoon. My name is Peter Haddon, and I'd like to talk about diabetes and screening and treatment in the South Pacific. So to put it into some context, the South Pacific's a big area. The Pacific Ocean covers half the surface of this planet, although it is not all ocean, but is instead dotted with many small island nations, especially in the tropical zone. However, the total population of Oceania is not much more than that of Kerala. And if you exclude Australia, PNG, and New Zealand, it is less than KOCHI. So we have a few patients spread out over a huge area, and this is a big logistical problem. Money is a problem for some of these small island nations, although many of them are dependencies, so healthcare is provided by their partner country, such as Australia, New Zealand, France, or the United States. There are also many other countries, China and the EU spring to mind, as well as non-governmental organisations such as Fred Hollows Foundation and the Mormon Church active in the Pacific. So I should give you a bit of background. What's life like in the South Pacific? Well, of course, there's Australia, and there's Sydney, and where I'm from, New Zealand, and this is the climate I'm more used to. But I want to talk about the small tropical Pacific Island states, which my wife and I love to visit with our children. So, although there are a couple of small cities, such as Apia on the top left, Suva in the middle, and Nandi on the top right, although I think most Indians would call them towns and small towns at that, most people in the Pacific live in villages such as the ones shown on the bottom. The church is very important to most Pacific Islanders, and the pastors are often the best placed people to know what is going on in their village and organise things like diabetic screening and treatment. I have to mention at this point that there's also a substantial Indian population in Fiji, and Nandi even boasts a Hindu temple, the largest, of course, in the South Pacific. So diabetes is a massive problem in the South Pacific. 29% of the population are diabetic. That's been estimated this year. Perhaps some of it is a genetic predisposition, but maybe not, because I've just heard that in urban India, the diabetes prevalence may be up to 30% too. Food is definitely a big culprit. So if you look at the 10 most obese nations in the world, they're all in the South Pacific. And of course, obesity is a huge risk factor for diabetes. Diabetes in the Pacific is often underdiagnosed, under-monitored, and under-treated. It is sometimes hard to even to get diabetic medication, and that can run out easily in the pharmacies. There's a lack of glucose monitoring, and people don't even know much about it. The culture also promotes big eating. For instance, after church on Sunday, everyone goes and has a big feed for the rest of Sunday, and if you don't partake and don't eat at all, that's just not done. There tends to be sugar in everything. And obesity, of course, also causes hypertension, which just makes your diabetic retinopathy worse. And in many places in the Pacific, there is also often no monitoring for a diabetic eye disease. So the sort of presentation we see is often late, with people having had little or no treatment. And obese patients are also difficult to examine, as I'm sure you can appreciate. So this is just patients I saw a couple of weeks ago in Samoa, sort of presenting for the first time just like this, with large exudation, or a bit hazy, or gross neovascularization, although these were just, 3 patients on one day. And many of them can be worse. This one at least hasn't got a total traction or retinal detachment on presentation. I'm sure that's not novel in India either. So what resources are there for these patients? So in the independent Pacific nations, Fiji being the most populous if we exclude PNG, is also the most well served. In 2 divisions of Fiji, there even is a diabetic photo screening service and a travelling eye bus, which you can see on the right. Other countries aren't quite so well served. Samoa only has 1 resident ophthalmologist, and that person is leaving. There are visiting ophthalmic teams that come several times a year, but really people have to be lined up by the ophthalmologist who's there already to sort them out beforehand, because it's difficult to just come, do stuff and leave. They do have TNI nurses who do screening, and they travel around both islands of Samoa. Tongatapu's got one resident ophthalmologist, which is good. And the Solomons actually have more than that. And one of the Solomon Islands, or both of the Solomon Island ophthalmologists also do help out in other islands. In those nations that are dependent on another country, there is a better supply of ophthalmologists in the largest cities, especially in the French territories. And patients who have problems that can't be treated locally are sent free of charge to the partner country. American Samoa is just about to poach the ophthalmologist in independent Samoa by offering her a larger salary. And on the smaller islands, though, independent and dependent alike, although there are sometimes nurses who have been trained at the Pacific Eye Institute in Suva, in many cases there is no eye health service. Sometimes there are visiting ophthalmologists, and there's a boat that sometimes goes around providing eye care. You've got to also remember some of these islands are widely scattered. This island, Pitcairn Island, for instance, it's too far to fly a helicopter to Mangareva, the nearest island in French Polynesia. It's quite rugged, as you see, so there's no airstrip. So the only way you can get there is once a month on a boat, which takes 3 days to get there. Tokelau's the same, pretty much, boat. So it's very difficult to get patients to and from these places, or even people to there. Perhaps the most important eye institution in the Pacific is the Pacific Eye Institute, based in Suva at the Colonial War Memorial Hospital. It trains ophthalmologists and ophthalmic nurses for all over the Pacific. It's funded by both private and public organisations, mainly in Australia and New Zealand. Vitreoretinal surgery. In the independent Pacific, there's only vitreoretinal surgery available in Fiji, and then only by one surgeon. So clearly, if he goes, that folds. Patients can often be sent overseas if needed. If you live in French Polynesia or Samoa, you may be funded for that. But not all independent nations are like that. In some, for instance, like Fiji, you have to pay to go overseas and for your surgery, unless you're friends in government. I know also some patients are sent to India for treatment. So how can we change this? First, we have to reduce obesity, education, and restricting the importation of certain foods into these islands. For instance, condensed milk has been banned and turkey tail have been banned from Samoa. In Nauru, all citizens are encouraged to run around the airport once a day. Try to do that in India with your population. We also need to improve the management of diabetes and diabetic retinopathy by training more doctors and nurses. Perhaps even we could send trainee ophthalmologists to India, especially because you're the world leader in 6, which is mostly what's used in these small nations. And with the rise of the internet, we could make online lectures available, and organisations such as ours, RANZCO, or the All India Society, I'm sure, have a lot of resources which would be easy to extend to these islands. We also need to institute more screening for diabetic eye disease. And on some of these small islands, you don't necessarily need an ophthalmologist. You just need to take a photo, and that can be read somewhere else by someone else or by AI. And of course, we have to have more lasers closer, lasers and injections and things closer to patients, together with appropriate servicing of those devices, because that's an issue too. They break down. And we need to have people who are appropriately trained to do injections, which need not necessarily be ophthalmologists, but it can be eye nurses, and vitreoretinal surgery for everyone, not those who can afford it or are lucky enough to live somewhere that provides it. So, thank you.
Thank you, Dr. Peter. We'll keep the questions to the end.
Okay. So right now we have Dr. Peter McCluskey. So could you give a presentation? His presentation title is Real World Experience with Adalimumab for Vision Threatening of Eyes.
Thanks very much. Apologies, I was late. Our session was running over. Are you going to change the slides over? Yeah. So I'm going to talk about biologics, which is, I suppose, the opposite end of the spectrum from, Peter Haddon's talk about outreach services in the Pacific. I actually used to run the eye clinic and the eye services on Norfolk Island, which is where most of the people from Pitcairn, no, that's not my talk,
Not this
I'm
one.
afraid.
The first one.
But as I was saying, I used to run the eye services on Norfolk Island, which is where a lot of the people who used to live on Pitcairn Island went to. And I thought it was hard until I heard your talk. Now I realise I had a very easy clinic to run. Not that one. I've got another copy. How about? Which one?
It's the one that says AIOC talks, and the one that says biologics, that one.
This is like a biologic that is used in treatment of uveitis, but it can be used for any other immunosuppressive therapy also.
Okay. Okay, so good afternoon again, everyone. So I'm going to talk about something that's at the opposite end, I guess, of the complexity spectrum, but it's really dealing or how we're using these new biologic drugs. And so I'm just going to talk about how we use these very expensive drugs in the units where I work in Australia. And basically I work in Sydney, and I also conduct an outreach clinic down in Hobart in Tasmania. And we look after a lot of patients with inflammatory eye disease. And I just want to go through our experience using TNF blockers, particularly adalimumab or Humira, which is the drug that we've got the most experience with. These drugs have only been available relatively recently and in Australia since 2016. And I'm going to go through some of the evidence, which is these visual studies, and then show you how our experience in Sydney matches those studies. So there were essentially two important studies of adalimumab. They were both randomised controlled clinical trials. The first, called Visual 1, was in patients with active uveitis, and as you can see, basically the adalimumab arm of the trial doubled the time to disease relapse, and it's a very powerful effect on a group of very bad, frequently responsive diseases. The other study that was done was a similar randomised controlled clinical trial, but on patients with uveitis where the uveitis was in remission, and a similar sort of sustained early effect on uveitis was found, and less than 50% of the patients relapsed over the time course of the study. So these two studies showed clearly that adalimumab was a very efficacious drug, and there were minimal safety signals, so it was shown also to be a safe drug. There was a low risk of any other side effects. The two important lessons that they learnt from these studies was how important it is to exclude infectious uveitis, particularly latent TB, which has to be treated before you use a TNF blocker, because that will unmask TB if you use a TNF blocker. And that's very important in a country such as India and in most of Asia and the Pacific, where latent TB is very common. The other important disease to exclude is demyelinating disease in patients with intermediate uveitis, because intermediate uveitis, a small number of those patients do have demyelinating disease, and again, a TNF blocker makes that reactivate and progress much more rapidly than it would. So in our small case series study that we did in Australia, we had 89 eyes of 46 patients. The majority of the patients had bilateral disease. The spectrum of disease is very similar to that that's seen in other parts of the world. 40% of the patients, there was no obvious associated disease. 20% of the patients were associated with anterior uveitis, and the other 40% was associated with a range of posterior and panuveitis, such as sarcoidosis, birdshot, Behçet's disease, and multifocal choroiditis. The usual reason that we escalated these patients to a biologic was either because that we were unable to control their inflammation, or they had progressing acute threatening disease that we were unable to find a treatment that worked well enough with minimal side effects for us to continue with that treatment. Occasionally there were other indications like side effects from their current treatment, or they needed the biologic for their systemic disease. This rather complex slide, basically what you need to look at is, as we go from left to right, the column of patients in the dark blue disappears, because the blue are the patients on steroids, and as we move from presentation to starting them on immunomodulatory therapy, and where we are then going to start them on biologic as well, to their final follow-up, you can see that we got all but one patient down to a safe level of steroids or to 0 steroids. The pink and red column in the middle are patients on a maintenance acceptable dose of steroids and a biologic, and the green column, which has got much higher, are the patients that are on an immunomodulatory drug and a biologic and are off steroids. And that's really the basic message of what adalimumab or Humira does, is it allows us to stop steroids and get patients off steroids and get them onto a stable steroid-free regimen of drugs that controls their uveitis. And the reason that's so important is that most of the side effects that we see in our patients in the longer term are related to steroids. Many, far fewer are related to the other drugs. Most are steroid related. The other important thing in this slide is in the red box down the bottom. Essentially, once we put the patients onto a biologic, patients stopped losing vision. The vast majority of them stabilized, and very few patients lost vision. It didn't really cause many patients to get an improvement in vision, but the key thing is it just stabilized and burnt out and controlled the disease at whatever level they were. And this slide illustrates that a little more easily. The blue are patients who improved in vision. The yellow or orange one are those that are stable, and basically the small column on the right are those that lost vision. And once we started the patients on biologics, patients stopped using vision, and the majority stabilized, and some had a further improvement in vision. And that's the first time in inflammatory eye disease we've actually been able to do this. Our experience in Australia is similar to the Visual 1 studies. The graph on the left are patients with active disease, and there's a profound sort of efficacy effect with that stops the uveitis relapsing, and it's similar in patients who have inactive disease when they were started on their biologics. And these two graphs are extremely similar to those that were found in the Visual 1 and Visual 2 studies. So basically, what I've tried to show you today is that this is real-world data that supports the visual studies. Using TNF blockers in our patients with vision-threatening uveitis greatly decreases the number of relapses. It greatly decreases the number of patients who lose vision. It basically stabilizes the disease and turns it off allows us to usually stop or at a minimum get the patients down to a safe maintenance dose of steroids. In the longer term, we can often stop their additional immunosuppressive drugs. And although we can't show it in this study, there's more and more data that shows the earlier you escalate treatment to a biologic, the better the outcome is. So what we do now in our clinic is when we see someone with vision-threatening uveitis, we start them on steroids, start them on a second-line agent, usually either methotrexate or mycophenolate, and try and stop the steroids. If we can, good, we just keep going with methotrexate or mycophenolate. If the disease relapses, what we do is add a biologic rather than going to another second-line agent, and that's increasingly becoming the treatment of choice. There's a very large randomised controlled clinical study that we're a part of called the ADVISE trial that's looking at the differences in outcome between doing that when the disease relapses, changing to a biologic versus changing to a second disease-modifying conventional drug. We don't know the answer yet, but we're about 95% of the patients are now recruited for the study. So I suspect we'll know within the next 6 to 12 months. The other important point is that our colleague Stephen Foster many years ago said that two of those famous American one-line sayings. The first was that the mission is remission. The most important thing we need to do in patients with uveitis is get the disease into remission. And the problem is, until relatively recently, we've always struggled to get the uveitis completely controlled. And more recently, the second important goal is that we need to get our patients, as they say, into durable steroid-free remission. We know that most of the side effects and most of the longer-term complications and adverse outcomes in our patients are related to steroids, so we need to get them off their steroids. And biologics are really the first time that we have a very effective, very safe, very well tolerated treatment that does those two things. So they're certainly the way of the future. Thanks very much.
Thank you. Thank you very much, Mr. Peter McCliskey. Yes, we'll have questions at the end. I would now like to invite Professor Nitin Verma. He'll be speaking to us on sustainability of eye care, all the way from his experience in University of Tasmania and Sydney. Thank you, Dr.
And for that to come on, that's on. Yeah, thank you. So and thank you for inviting us to come and be part of the All India Ophthalmic Society meeting. Representing RANZCO, I now speak on behalf of the Sustainability Committee of RANZCO. I'd like to acknowledge the members of the committee and also Dr. Thiel. So basically, what is this big thing about sustainability? It's big. I mean, you need to talk about sustainability everywhere, and then suddenly it becomes important. But really, it's about meeting the needs of the present without compromising the ability of future generations to meet their own needs. You can't talk about sustainability without climate change. And, I was so pleased to see when I landed in Cochin that the whole airport was powered by solar. And I thought, I've never seen something like this before. Well done and congratulations. But usually, it all starts with climate change. And these relate to unusual weather patterns, whether it be rainfall, temperature, or extreme this thing. We talk about greenhouse gases. We talk about the greenhouse effect, where greenhouse gases trap the heat on the surface of the earth, and then we get warming. People talk about 1 degree, 2 degree, that's all very good, but the bottom line is that warming is happening. In Australia, for example, the mean temperature is going up, the rainfall is coming down, and we are used to famine, we are used to flood, and we are used to natural disasters. But it's not only about Australia. You can see that India, for example, you look outside, you see this nice serene waterway with houseboats. But the heat waves are coming, and surely places like Calcutta and Bombay, or Calcutta and Mumbai are definitely, and perhaps Cochin are also definitely at risk with climate change. Now, with climate change also comes the inability of the population to feed itself, and it's possible that up to 63 million people may not be able to meet their calorific needs. So really, if the life of every child born today will be profoundly affected by climate change. And I think without doing anything, we are running into a big problem. It's not only on floods and famine, but also on human health. Lots of effects on the human body. Overall morbidity, mortality increases. There's a change in lifestyle, increased reliance on healthcare. And of course, we think there'll be more trachoma, the vitamin A deficiency, cataracts, and glaucoma. So I think we need to address this climate change business. And the IPCC has said, well, you could do this, you could do that. But basically, it's about what do we aim for. As doctors, we always like a sort of middle of the road approach. And I think really going down to about 2.4 degrees target would be something that we can at least hope to think of. Healthcare is a serious emitter of greenhouse gases. The healthcare sector is responsible for 10% of greenhouse gas emissions in the US. And operating theaters are, of course, a big culprit. And we as ophthalmologists have the highest surgical volume in medicine. So I think we have a rather big role to play. The feeling amongst cataract surgeons, or in fact all ophthalmic surgeons, is that everything is double packed, triple packed. And yet, if you look at the data as presented by David Chang, he says that the post-operative endophthalmitis rate in the Arvind Eye system is less than what happens in the United States. Now, we're doing something wrong, aren't we? But let's look at what we can do to reduce all this by maintaining a high standard of patient care. So looking at decarbonizing your hospital practice. Now, this is an example from New Zealand, where that little area at the bottom is Wellington. We've got a lot of old people living on the way, and they come down for their intravitreal injections, bypassing many small clinics and regional hospitals that exist. So certainly reducing transport emissions would be something that we can think of in many situations by providing better transport. Cataract surgery can also be footprinted in terms of its carbon emission. If you look at the UK and you look at Wellington, they all have 180, 150 kilograms of CO2 emission, and yet you look at the Arvind Eye system and it's down to 6.2 kilograms. So we can do all this. What does 152 kilos of CO2 mean? It is the amount of CO2 that's emitted by one person living for 5.9 days. So you can imagine how much carbon is being produced by one cataract surgery. And even though New Zealand has renewable energy, but it still has a pretty large carbon footprint. The issue, of course, is procurement, and all the pack, repack, and sometimes something's put on the table and one doesn't use. I think we just need to start thinking of reducing, reusing, and recycling. Now, that's what you produce from one cataract surgery. And that's one of our committee members from the Sustainability Committee. And that's his cataract output for one day. That's his cataract output for 1 year. I mean, I think it makes a pretty compelling picture. So there are many ideas that we've got, but really it goes down to, reduce, reuse, and of course, if we look at other ways of doing cataract surgery, such as small incision cataract surgery, which is still the most common form of cataract surgery in the world, we have a much smaller, lower carbon footprint. And I don't even want to go to intravitreal injections, because that is something that's just gone up in such an exponential fashion that I think we really need to think what we are really doing. So think about it when you're in theater next time, and when you leave the theater, ask your staff, well, are you putting the lights off? Are we using LEDs? Are we turning the air conditioning down? Because that's a serious source of CO2 emission. The NHS also has added one more thing to the mix, which is the use of gases both by the anesthetist and my retinal colleagues, because these also add on to the greenhouse gases. So here are the 5 R's. that one needs to think of. But it's not only about climate change. There are also other aspects of sustainability, which I won't go into in detail, but financial sustainability. There's no point in setting up a system that can't run itself. And again, economics sustainability. And there's a good article by David Green, even though it was published in 2001, which really, as an ophthalmologist, because ophthalmologists are also business people. They run a practice, they run a hospital, they run a system. And really one needs to think about how we are going to, and are we doing it properly? And I think in this regard, there are a number of good examples in the region, in Southeast Asia and India and Nepal, where they lead the way in eye care delivery to the community. The charity dollar is another area of waste, if not used properly, because the charity dollar is something I always feel people give for charity so that they can say, okay, just leave me alone and let me get on with my life and sort of, don't worry about those guys. But that charity dollar can be converted to a charity business dollar, where it can then start a process where things carry on for the future. To include things like gender balance or imbalance, diversity and inclusion, and setting up a sustainable workforce. In RANZCO, we have a policy where we would like to have at least 35% or more of female participation. We also look at sustainable work practices, and I think COVID has really changed a lot of that when we take the balance between working at home and working in the office, as has been the use of telehealth. So, what have we done as a college? We did a survey and found that 68% of our fellows agree that climate change is a big deal. And those who lived in the bush or out in the villages actually didn't seem to agree on this. And most of them agreed that we better do something about it. So the UN Sustainable Development Goals, or the SDGs, there are 17 of them. RANZCO has started and adopted 8 of them, which we can do something about. RANZCO has a big program setting up eye care for the future, which is called Vision 2030 and beyond. And there's a similar program in New Zealand. But one of the big pillars of this program is sustainability. So whatever we do, sustainability comes into it. This committee is involved with advocacy, education, awareness raising, and also highlighting important examples in the world, such as the Arvind system. We have prepared practice guidelines for reducing waste in cataract surgery, and I think the Sustainability Committee is an important committee that reports directly to the board. We need to make a call for doing something, and I think as doctors, we are well respected in community. I think this is really a call for all doctors to act. This compelling picture I show you again, because what's happening right now is we are not really shaping the future. I think we need to do something about that, and I think it's time we did it. So, thank you.
Thank you very much. I think the sustainability is a very important issue for global. Okay, thank you. So I'd like to invite Dr. Vignesh Raja. He's talking about artificial iris implantation techniques.
So good evening, everyone. And thank you very much to AIOC for our invitation to RANZCO to speak at the conference in Kochi. I'm just going to be talking about artificial iris implantation techniques. This has been around for some time, but I was quite stubborn to the idea of using this because of the cost involved in using artificial iris, because the artificial iris is quite expensive. It costs about $2,000 for a standard brown one, a standard color one, and a custom made one is about $8,000. So that is roughly about 1 lakh for a standard color and 4 lakhs for a custom made one, comparing the other eye. But it has got its role in reconstruction of eyes after trauma. So this is an artificial iris model, from the Human Optics company in Germany, which is biocompatible, foldable, and it's made of silicone elastomer. And it's got two versions. It's got one with fiber and one without fiber. So the fiber-free one can be used, in the bag or in the sulcus, whilst the one with fiber is more rigid and it's used for scleral fixation. Because I've got quite a few videos, I'll skip the theory and go straight to the videos. So you can implant the artificial iris either in the capsular bag or in the sulcus, or you can also scleral fixate it with Gore-Tex suture, or you can do an iris and IOL complex fixation. So here is a case. This was my first case of iris implantation in a phakic eye with a permanently dilated pupil secondary to injury. And he had a dense cataract, so let me just fast forward the cataract, because I'm sure you all can do a cataract better than I do. Okay, so I'm injecting a capsule tension ring because you want to expand the bag nicely. And here the lens goes in the bag. And here what I'm now going to do is I'm actually going to place the iris prosthesis in the bag on top of the intraocular lens, and that's why you have to stretch the bag with capsule tension ring. So here's the artificial iris being opened up. And this is a standard brown. It worked well because the patient's other eye was also a brown in color. And this is the fiber-free model. It comes in 10 millimeter in diameter. So then what you need to do is use a trephine to measure use the trephine to cut the approximate size to 10 millimeters. And here, because you're placing it in the sulcus or in the bag, and you can actually place it in an injector and fold it. And now you can inject this. And then again, I'm visco, expanding the bag. And because the bag's nicely expanded with capsule tension ring, I'm now injecting the iris prosthesis in. And once that is in, you need to do a bimanual approach to actually position this inside the bag. You can either place it in the sulcus or in the bag, but I just chose to put it in the bag this time. And I'm just nudging it to make sure it's absolutely centered. So this is the fiber-free model, and the pupil diameter is fixed at about 3.8 millimeters. So it is convenient for fundus examination and what have you. Okay, now let me go to the next one. So this is a person with all of these are after penetrating eye injuries where they've lost the iris completely. So here, this person had about 3.5 or 4 diopters of astigmatism. And as you can see, the person has total aniridia. So what I've planned to do is I've planned to implant a scleral fixated toric intraocular lens, and at the same time, after that, to implant the artificial iris prosthesis. So I'm now doing vitrectomy to clear out all the vitreous, because the last thing we want is a retinal complication later on. And I'm using 25 gauge trocars. So I've made two points, 1.5 and 3 millimeters from limbus. So 2 sclerotomies radially and then line with each other. And I'm now extending the corneal wound to about 3.5 millimeters. I'm using an Envista toric lens there, and I'm passing a CV8 Gore-Tex suture through the eyelet in the Envista toric. And this is a nice lens for scleral fixation because it's a hydrophobic lens. So here I'm cutting the haptics off, and I'm externalizing the Gore-Tex sutures. So the Gore-Tex sutures that are passed through each eyelet, I'm externalizing them. Likewise, I'm doing it on the other side. So that I'm actually putting the Gore-Tex sutures on the axis of the steep meridian. And you gently pull on these sutures now, and then it straightens up the lens very nicely. So as I tighten up the sutures, you can see that the lens is well centered, and the toric marker on that lens aligns with the axis marks that we've made. And what we should do is we must take care to actually bury these Gore-Tex sutures inside, because if you leave them outside, they will melt the sclera around it, and they can cause a conjunctival and scleral erosion as well. So now that I've fixated the toric lens, so now I'm going to implant the artificial iris prosthesis on top of the intraocular lens. I'm again measuring the white to white, and I'm taking the 10 millimeter trephine. And whilst trephining, you got to make sure that the trephine doesn't slip, because the trephine is extremely sharp. So what I do is I take a Moorfields forceps and press on top of the trephine so that you get a clean cut. And now I'm passing 2 Gore-Tex sutures through the prosthesis. And you got to make sure that the Gore-Tex sutures have to be passed at least 1 millimeter from the edge, because you don't want it to cheese wire. So I'm marking to make sure that we have at least 1 millimeter from the edge. And this is quite rigid, actually. So again, I externalize the Gore-Tex sutures out. And these I've made them, limbal, circumferential around the limbus rather than making them radial, so that then they are tied nicely apart. And all this is at 2 millimeters from the limbus. And this, you can put this in through a 4 millimeter corneal incision. So now I pulled up the sutures. So the only thing is, when you look at it closely, you see these 2 white lines on the brown iris, but I think who cares when the eye is aphakic and it's got such, such a bad preoperative outcome, a preoperative state that, this is better than nothing. So then I again tuck the Gore-Tex sutures in, and I'm now using glue to glue up the conjunctiva without any sutures. So this is my next case again. Oh, no, I'll go on to the next one. So this is another case where, again, the eye is completely aphakic, and there's this huge iris defect, and there's just a small ischemic strand of iris across the pupil. And all these patients have had severe penetrating eye injury. So what I'm doing is I'm marking 3 millimeters from the limbus and 3 millimeters on either side of that mark, and I'm making a scleral tunnel. And I'm now putting the vitrectomy ports inside. And I've overshot the time. Is that okay? Sure. Sure. So what I'm now doing is I'm actually implanting the complex of both the micropure physiol lens and the iris at the same time. the lens has eyelets, so I'm actually putting the Gore-Tex suture through the prosthesis, through the iris implant and through the lens on both sides, and I'm going to fixate the whole complex in the sclera. So this is the undersurface. So when I turn it up, because from my previous case, I didn't want those two lines to be seen on the iris. So that's why I put it upside down. And so now I'm just going to put the whole complex in. And that's why I made a scleral tunnel, because it's quite, large. And I again do a 3-1-1 with the Gore-Tex sutures and then tuck them in. So at the end, I tuck all the sutures in and I put glue to close the conjunctiva. In the interest of time, I'll skip through my last video as well. So in fact, artificial iris prostheses have a role to play in reconstruction of post-traumatic eyes, especially in countries like, when you live in a bright country and you have, total aniridia, and there is the glare can be debilitating. So they have a role to play, and there are quite a few techniques. There is another technique where I did a Yamane with this, but in the interest of time, I'll show it later probably. Thank you again.
Thank you so much, Dr. Raja. That was really interesting. First time I have seen it, and it's so slick. Thank you very much. I would now like to invite Dr. Peter Hayden again to give his talk on management of metastatic diseases of the eye.
Sorry, I'm afraid you get a bit of me. I'm a vitreoretinal surgeon, but I also do the adult intraocular tumours for New Zealand. But we're a small country, so it's really only part-time. I would like to talk about the management of ocular metastatic disease. And of course, the most common site for metastases is the uveal tract because it's highly vascular. The vast majority are in the choroid and almost half in the macula. So our candidates, when they come to our final exam, usually quote this study by the Shields in Philadelphia when asked as to the relative frequency of different primary tumour sites, and they say the most common are the breast, then the lung. However, you've got to consider where the study was done, and it's going to vary by region. I mean, even in other parts of the same country, for instance, in the southeast, where smoking is more common, lung cancer predominates. And of course, when stratified by gender, clearly breast cancer is not going to be the most common cancer among men, although it can occur and is associated with a higher chance of metastatic disease. So many patients with uveal metastases are asymptomatic, although the most common symptom is blur, followed by photopsia and pain. Pain's not that common, but it's very rare in other ocular tumours. Many don't present, of course, because they've got metastatic disease elsewhere and they've got other concerns that are greater than just having blurred vision. Generally, metastatic tumours are yellow, although there are a few that are typically orange, and metastatic melanoma is usually brown. On ultrasound, they're often of a kind of medium to low echogenicity, relatively low and flat, often associated with a large serous detachment, although by no means always, of course. There are also changes you can see on OCT and fundus autofluorescence, but while they've been described, they're not diagnostic, and they're certainly not diagnostic of the site of the primary tumour, so it really doesn't help that much. Of course, in the differential diagnosis of a uveal metastasis, you've got to think, particularly in New Zealand, of non-pigmented nevus or melanoma. I guess uveal melanoma is less common in India, although I do see it's on the program, because they can be non-pigmented as well. And in fact, 70% of all non-pigmented tumours are said to be melanocytic. There are also quite a few rare benign non-pigmented tumours as well, although some not so rare, such as osteomas. And lymphocytic tumours can also look very similar. The second most common site of metastasis is the orbit, with the other sites extremely rare. In the orbit, breast again is said to be the most common primary site, although again the prevalence depends on geographical location. For instance, quite a high chance of it being hepatocellular carcinoma has been reported from Egypt because apparently hepatitis A is very common there. Orbital tumours usually arise in the orbital fat or rectus muscles and present as a solid but usually somewhat poorly circumscribed mass. Bilateral disease is actually rare. Bony erosion is unusual, except that prostatic carcinoma tends to metastasize to the bone. I remember from when I was a trainee being taught that breast cancer often causes enophthalmos, and due to contraction of the stromal tissues and a reduction in the orbital fat. Actually, this is not the most common presentation of this disease, and the term that I learned, scurus, also no longer appears in the breast pathology literature, and therefore perhaps should no longer be used. And here is the relative frequency of the various symptoms and signs of orbital metastases, with proptosis clearly being the most common, followed by visual loss and strabismus. So the workup of a patient with a suspected metastasis depends, of course, on whether the primary is known or unknown. The latter need much more in the way of workup, of course. The former, though, you should always tell their oncologist that they've got it, because it may change, they may need to restage them systemically. But 1/3 do have no known primary diagnosis, and these patients clearly need a thorough workup. The most obvious question to ask, of course, is, are you a smoker? Generally, I do a PET scan on these patients, although in a smoker I might start with a CT chest. So how do we save the eye? Sorry about the New Zealander making the catch, but our goal, of course, depends on the patient's systemic status and the treatment burden, as these sick patients may not wish to have a lot of additional treatment for the small amount of time they have left. However, even a patient with only a short time to live doesn't really like to go blind. Often, of course, the systemic treatment that a patient is on will also treat metastases, and because of the choroid's fenestrated epithelium and high blood flow, there is often good drug penetration. And of course, there are many of these treatments which a patient may go through and beyond, which may be used by themselves in combination or in combination with a local treatment. However, the definitive local treatment really is external beam radiotherapy. The main thing about this is to make sure there's no CNS disease at the same time, because you want synchronized therapy. It's not good to irradiate the eye and a bit of the brain and then irradiate the brain again. Higher doses are used for short-term palliation where side effects are unlikely due to the patient's life expectancy. So here's a patient who had lung carcinoma metastatic to the choroid. You can see 18 months later, so they do live a while. There's little left superiorly, bar an atrophic scar. Inferiorly, the tumours are much reduced in thickness and the serous detachment is gone, and you're really just left with a pile of soot. I've also found photodynamic therapy very useful, although Visudyne is hard to get hold of, I think, worldwide at the moment. However, it is a quick and easy treatment when it is available, and you can just do it on the spot. You don't have to wait for them to be booked in for radiotherapy. So here's a 42-year-old patient with lung metastasis just before he had PDT, and here he is a month later, looking a lot better, although his vision didn't improve much. You can also use brachytherapy and shrinks metastases very effectively, but of course it's a bit more invasive. Other local treatment options can also be used, such as transpupillary thermotherapy. I've used TTT, but not as a treatment for metastatic disease, so I don't have experience with these. The ocular prognosis depends on the location, size and number of metastases, of course. I mean, if the tumour is already infiltrated under the macula, the vision's likely to be lost and remain lost. But small extrafoveal tumours can do very well. How does it all work out in the end? Well, overall, of course, the main determinant of longevity is the type of underlying tumour. Just to finish off, well, to cover all the bases, retinal metastases are very rare. However, vitreous metastases are becoming more common. especially in patients with metastatic cutaneous melanoma, because the checkpoint inhibitors that they now put these people on treat this disease very efficaciously elsewhere, but because of the eye's status as immunologically privileged site, they may not be able to get into the vitreous, which makes it difficult sometimes to convince the oncologist that they've still got anywhere. And people are still experimenting with what the right treatment is for these, but a vitrectomy or external beam or maybe intravitreal Malfilan or some of these in combination may be the treatments. So and then just finish off with a few photos of New Zealand. Thank you.
Thank you very much. So, I'd like to invite Dr. Vignesh Raja again. His second presentation will be the title will be Ultra-Wide Field Angiography in Diagnosis and Management of Retinal Disease.
While we are waiting for Dr. Raja to set up, are there any questions from the floor for any of the speakers so far? Could I ask one question to Dr. Peter McCliskey? You know, you've been using this only in non-infectious uveitis, and one of the known side effects for these biologics has been that suppression may cause secondary metastatic or cancer diseases to flare up. Do you see that in your practice? And I mean, have you ever experienced using this drug in a carcinoma of retinopathy?
Yeah, the good thing is that the evidence shows from those large studies that the risk of making cancers grow or making metastases occur is extremely low. The SITE study shows that our conventional drugs are safe and don't cause lethal malignancies, and the evidence from particularly from the rheumatic literature, shows that there may be a very small increase in lymphomas, but there's really no other signal that says that cancer is more common in patients who are treated with biologics. Because in rheumatology, we've got nearly 25 years experience now. So they're very, very safe drugs.
Yeah, thank you.
So my next talk is going to be on use of Optos ultra-wide field imaging in diagnosis and management of retinal disease. So there have been fantastic advances in angiography now. You know, the standard FA, we used to see only 30 to 55 degrees, and we had to do a 7-field montage to see the periphery. But now with the advent of ultra-wide field angiography with Optos or Zeiss Claris, it has allowed us to capture about 200 degrees in one field. And this helps capture peripheral retinal pathology, which can change the diagnosis and management. So I'll run through a few cases where it has actually changed, the management plan. So this was a 55-year-old lady from the country, in the outback bush, who was referred for diabetic screening. Dry AMD, the family history, type 2 diabetic for last 8 years, and myop. And you can see in the picture that she's got, features consistent with very severe non-proliferative diabetic retinopathy in both eyes. And, I like to put the autofluorescence image here as well, because sometimes the autofluorescence image shows up, neovascularization pretty well. And here's the OCT, which shows, essentially a dry macula with some cystic chain superiorly. And this is the other eye. The macula itself looks dry, and there's some swelling above and below. So here's a standard 55-degree field angiogram. which shows features consistent with, with very severe non-proliferative diabetic retinopathy. But then when I put the patient on the ultra-wide field, you can see the staining and the capillary non-perfusion areas, in the extreme periphery. This is the right eye, but look at the left eye, which is even worse. And this tells you that this patient is almost pre-proliferative or going to become proliferative very, very soon, because the ischemic index is quite high. So what we did is because this lady, lives in the bush, and considering her very severe NPDR with significant peripheral retinal non-perfusion, I treated her with targeted pan-retinal photocoagulation laser, and the ultra-wide field angiogram actually helps map out these capillary non-perfusion areas so that you can treat them with targeted PRP. So, in fact, if not for ultra-wide field angiography in this case, I would have just continued to watch maybe till signs of early proliferation. But the problem is when they live out in the country, the visits are less frequent, and then by the time they come back, I might be seeing them with high-risk PDR or vitreous hemorrhage. And let me go to case 2. This was a male who was referred for diabetic retinopathy evaluation because of a hemorrhage in the right eye, and this person had PRP both eyes. And you can see from the picture here that there is PRP scars and a subhyaloid or a preretinal hemorrhage there. This is the other eye. And here's the angiogram. You can see some leakage consistent with the NV inferiorly. And this is the other eye. But when I put them on the Optos, you can see the persistent, capillary non-perfusion and ischemia in the extreme periphery, despite mid-peripheral scatter PRP. So this clearly shows the inadequacy of previous PRP, but I just thought it's an interesting case, which has developed, neovascularization at the junction of the non-perfused and perfused retina, despite PRP. So I treated this person with additional PRP, and you can see that the neovascular, membrane, the neovascularization with the subhyaloid, the preretinal hemorrhage has nicely resolved. So this is case number 3. This was a 35-year-old lady who was referred by the optometrist for evaluation of retinal hemorrhages left eye on routine dilated fundus exam, and no previous family history. And you can see in this image that there are some hemorrhages in the extreme periphery. So then here's the OCT, which was basically normal. So OCT is normal in both eyes. And here I put it on the ultra-wide field angiogram, and you can see abrupt termination of the retinal vessels with straightening of the vessels here. And if I show you one with steering, here it demonstrates avascular retina with early neovascular buds there. And this gives you the diagnosis. And if you look at the other eye as well, the right eye, you can see complete avascular retina with early neovascular buds. So this changes the, this was a case of fever. And of course, the differentials here are ROP, but the patient was not born premature. So here, the ultra-wide field angiogram helped diagnose and stage fever. And it shows you both the, all the changes consistent with fever, and confirms both anatomical and functional changes seen in cases of fever. This is case number 4. This patient was sent, for blurry vision in the right eye, with vision of 636 improving to 612. And if you look at the fundus, you can see, exudates in the right macula. The left eye is completely normal. So normally we think maybe this is branch retinal vein occlusion. That's the most common. But then here here's the OCT, which shows significant cystic change with hard exudates in the macula, in the right eye, and left eye is completely normal. Patient's not a known diabetic or a hypertensive. And here's the standard 55-degree angiogram. Here I'm particularly looking for AV delay or AV delayed transit, which is consistent with retinal vein occlusion, but I can't see any. And there's significant leakage in the right macula. But when I put this patient on the Optos ultra wide field, look at the peripheral telangiectatic change, the budding, the neovascular buds, and all the type 1 aneurysmal change. So this changes the diagnosis. This is a MACTEL type 1 or idiopathic retinal telangiectasia, a variant of Coates disease. So this patient has been treated again with a combination of anti-VEGF and laser to those areas. But this is quite stubborn. You know, I warned the patient that this will not get better very quickly. And this is case number 5. He was referred for, again, retinal hemorrhages left eye. Here he's got hemorrhages here, just in one eye. So the differentials here were either carotid occlusive disease, ocular ischemic syndrome, or central retinal vein occlusion. You can see that the veins are dilated. So we did an angio. This is the right eye, normal. And the OCT of the right is normal. And the left on presentation is also normal. And here you can see delayed AV transit in contrast to the previous case. So which clearly shows that this is a retinal vein occlusion. And the Optos ultra-wide field shows well-perfused retina. So I diagnosed this as non-ischemic central retinal vein occlusion. And then the patient was on 6 weeks follow-up, and then 3 months and 6 months. But it comes back 6 months later with this. Vision of 6.6 is now dropped to 6.36. And look at the hemorrhages again. So I treated the patient, with anti-VEGF. And then I did an angiogram 2 weeks later. And you can see on the angiogram that now this entire area, you can see capillary pruning there, and the entire area has gone ischemic. So here, this, this clearly shows that a conversion of a non-ischemic CRVO to an ischemic CRVO over that period of time. And in contrast to the baseline angiogram, this shows you that the ischemic process has been slowly evolving. And so this patient was treated with a combination of anti-VEGF and targeted pan-retinal photocoagulation laser, but the disease is still stubborn and quite aggressive. So to summarize, ultra-wide field imaging and angiography captures peripheral pathology and shows the full extent of disease and helps determine treatment pathway. Thank you again.
Thank you, Dr. Raja. And with that, we come to our final talk for today. Dr. Hayden again will speak to us on penguin visual system.
This is just a bit of fun, really, a bit lighthearted, but I'd like to talk about penguins. If you can put my slides up, please.
Peter, while you're there, may I just make a comment on your first talk on Peter?
As under number 3, folder number 3. No.
The last one.
Number 3, and then Penguin India. Thank you. Okay. So New Zealand hasn't got as many people as India, but we've got more penguins, and they've been a bit of a research interest for me lately. And I've drawn this talk from a few of these papers that we've published on this topic, because no one else has really looked much at penguin vision. So why penguins, I hear you ask? Well, I need to start the movie, please. So there's actually there's sound that goes with this, but okay. I may be biased, but you have to say that penguins are pretty special birds about which we...
Every winter for protection against the bitter cold, because these little fellas can do something no other penguins can. Isn't that amazing? And how do they use this incredible ability? Well, they fly thousands of miles to the rainforests of South America, where they spend the winter basking in the tropical sun.
So unfortunately, the penguins I have been studying are flightless, but they do have some pretty impressive abilities otherwise. They can swim, and they occupy a large range of environments from the equator to the Antarctic. And here's just a few selections of penguins in different environments from the Galapagos to Antarctica. So flightlessness is actually an advantage for vision because it allows a large eye. If you consider a volant bird, it's got two heavy fluid-filled balls at the front of its head, and this is a problem for balance. But if you're flightless, this is no longer a concern. So you can see a large eye on one of our pictures that we drew of a dissected penguin head. The eye also can be protected by large muscles and thick bones where the skull doesn't cover. And you can see in the top left there's actually a ring of bone and just behind the cornea, just behind the limbus. A big eye, all other things being equal, allows the possibility of greater spatial resolution because there are more photoreceptors. And the larger pupil of bigger eyes is going to reduce diffractive limitations, although it will increase aberrations. It will also increase light gathering. This could be important because depending on the species, penguins have to operate in depths down to 500 meters, where the illumination is obviously going to be very low even during the day in tropical waters, but you can imagine in Antarctica in the winter where it's night pretty much all the time, it must be virtually black. So the avian eye has a number of features that distinguish it from placental mammals, including bony elements within the eye. These include that sclerolostical ring that I noticed here in the little penguin, which may protect the eye and allow a firm attachment for the muscles that move the eye, and also it may change the lens contour, allowing accommodation so they can see close up and far away, as well as change the focus underwater. They also include in some penguins this bony os opticus, as you can see in number A, which doesn't occur in all penguins, interestingly, and to which the muscles that move the nictitating membrane, the third eyelid, appear to attach, or at least lie under, as you can see in number B. Penguins, though, were found differ from other birds that have been studied. This is the jugal arch, in some ways equivalent to our zygomatic arch, but not phylogenetically the same. Birds are usually described as having 3 bones in the jugal arch, and you can see that in the little penguin there are indeed 3 bones. We've got a micro CT with the bones coloured different colours. But in the Gen 2, which you can see in the photo above and the line below, it's only got 2 bones. So that's an unusual thing. Birds also have a pecten, a group of vessels that protrudes into the vitreous cavity to nourish the inner retina rather than retinal vessels. And here you can see sticking out from the optic nerve in a Gen 2 chick, the pecten. You can also see a very fibrillar pars plicata, a rather flat cornea, and one of the muscles that moves the nictitating membrane just adjacent to the optic nerve. So some people used to think that penguins are myopic on land so that they can see underwater. The opposite of humans, of course. When you're swimming, you can't see underwater because you're out of focus. However, our measurements show that this is not so. We've refracted them both in air and underwater. As you can see, one of my colleagues performing retinoscopy on a sedated penguin here, and they're emmetropic in both environments. How do they do this? Well, basically they wear goggles. They can also accommodate up to quite a bit, and we think they can accommodate up to 39 diopters in the case of the small eyes of the little penguin. The goggles are their very flat corneas. The top one shows a Gen 2 penguin, and you can see its keratometry flatter than ours. The bottom one is a king penguin, which is a bigger eye, and it's got a very flat cornea. So it doesn't have as much of an accommodative burden when it suddenly goes from air to underwater. Penguins are also have very interesting corneas in other respects also. You can see that the cornea looks quite different from that of the human. Here I've got a human confocal and a king penguin confocal. For instance, the stromal cells are arranged in a lattice-like pattern, and they don't have the same superficial nerve plexus that we do. We're not sure why this might be, though. We wondered perhaps because they're trying to transmit UV light? So if you can play the next video, please. Or maybe I can start. So here I am holding a
Yeah, definitely.
I can't see it, you can't see it on the snow.
Yeah.
Clearly the Gen 2 penguin can. But there are problems with seeing UV. As you know, short wavelengths give more chromatic aberration and therefore blurriness, which is particularly a problem if you're aiming for high definition vision. And humans actually have pretty good spatial sensitivity compared to most animals. So then we looked at the optical transmission of the penguin eye. Interestingly, the king penguin, which has a bigger and therefore potentially better eye in terms of visual acuity, doesn't let through UV light. You can see the difference between the little penguin in the blue and the king penguin in the red. The little penguin has a smaller eye and does let in UV. Could this be due to the fact that the king lives further south than the little? The little lives in New Zealand generally, in southern Australia, and the king in the subantarctic islands. Well, we don't think this is the case because some Gen 2 penguins, which also let UV light through, live further south on the Antarctic continent itself than any kings. So perhaps it may be to reduce chromatic aberration and improve their vision because they've got better vision. Also, you can see the visual pigments where they absorb light. All visual pigments absorb light in the UV spectrum. So if you're trying to differentiate colours, seeing UV may be an issue because you're going to find it more difficult to differentiate the colours. But of course, we had to check out their visual acuity too. So if you can play this video. So some penguins, stripes as we're moving them around on that wall. You can see actually a lot of penguins are interested in these sea stripes. But we wanted to test how really good they are. And if you play this video, we made a little program and shone these very small stripes at a wall and saw if they followed it. And if you can play the video, please. Start getting interested in this. Following it. And it followed it to about 624 level. And it also seemed to follow just the same when we stimulated the long wavelength cones and when we stimulated the short and medium wavelength cones. Because some people want the birds may have two different visions with different cones. So their vision's pretty good, actually, but not quite as good as ours, despite not having a fovea, which is what in humans we associate fine vision with. So you can see the human OCT, and here's the king penguin OCT. What matters, of course, though, is not the fovea, but the photoreceptor, in particular ganglion cell density in the central retina. So there's a stain of the ganglion cells on the flat mount of the king penguin retina. And so luckily, although there is not a fovea, they have a very complex retina with lots of cells and processing within it and very closely spaced photoreceptors, as you can see. On the left is a light micrograph of the Gen 2 retina, and on the right, TM of the king retina with its closely spaced photoreceptors. And you can see also the very thick inner nuclear layer. So in summary, penguins, I think, have amazing eyes, and I look forward to finding out more about them. And thank you.
Thank you for the nice presentation. It is my first time to hear about the penguins' eyes. Okay, we have a few minutes for our discussion. So first, we'd like to ask a comment from the panelists. So are there some comment or questions for the panelists?
Have our panelists used the iris device? I mean, I have been trained to use. Dr. Gopal, yes, please.
This with respect to the presentation on the ultra-wide field photography. I was wondering, do you think our practice pattern will change with time where we may use it as a primary screening tool when the patient walks into the clinic. And only if you require dilation and examination, you do it later. But you just take an ultraviolet field picture, see the fundus. If everything is good, what is the need to dilate? And you can also focus your attention on the area of interest much more easily and identify the lesions than trying ourselves to identify the area of location. Do you think it would change our practice pattern in the future?
All the optometrists already have Optos, the basic model, and they do Optos ultraviolet field imaging for everyone, as a part of a screening tool. But eventually, that will become.
No, I'm talking about even an ophthalmologist practice. We can probably use it as an additive to our capacity to identify lesions.
Yes.
So you can focus your attention on an area of interest.
Correct.
Than diffusing it all over the fundus.
Yeah, no, that will happen for sure.
So what kind of complication, what is your series of follow-up for this artificial iris implantation? So I was just wondering, like in most of the cases of traumatic or a congenital aniridia, there is always a possibility of glaucoma, which is, the remaining iris is still remaining there. So I was just thinking of that is another part which we need to look into. Yeah, I was just thinking, wondering, just taking your opinion as well, whether the cutting of another remnant of all this iris tissue, is it a good idea, or do you think it is, because that remnant tissue again can go back and block the angle a little more. So if you can cut it, and then will it be a better idea, sir? Inflammation and.
No problem.
In fact, while cutting that stump, I had the endodiathermy ready on standby. Like if it bleeds, I could just use the endodiathermy to.
One hand with the endodiathermy, one hand with the cut.
No, actually, what you ask about our keratoprosthesis, artificial keratoprosthesis, they just strip that off whole thing, that area of exactly at that base, so it doesn't bleed that much, surprisingly. But glaucoma is a significant issue. It is there.
I was just going to make a comment about the wide field angiography, not so much on the angiography, but you can do angiography. We've done on a 1-month-old baby using the Optos system. So it's really good for children if you want to do that. But just in general, Optos imaging for children has changed how we run our service at the hospital, particularly if you want to look at babies with and young children with inherited retinal disease. Optos photography has just changed our ability to get really good images, and very importantly to get fundus autofluorescence, which is such a great game changer for assessing all of these patients.
I was amazed today. I attended a talk where they used it for ROP babies as well. That was amazing. One more question that I have. Yes, Dr. Giri.
Yeah, I had a question to the first presenter regarding the diabetes in the Pacific Islands. Now, how do you follow up these cases? I mean, you do the screening, but long-term follow-up, how do you manage that? Do you have a database, or how do you really? Because prevention, treatment is not a one-time process.
That's difficult. You've pretty much, especially if they're from more remote islands, do everything you can at the one occasion. If they're in a larger one, such as Samoa or Fiji, they can be followed up by a local ophthalmologist. But yes, it's a big problem. So if they come to us and we've got to treat them for their proliferative diabetic retinopathy, we just do absolutely everything at the one time, make sure they're fine before they go home, and then hope, really.
It's a challenge.
It's a challenge. For instance, if they go to Pitcairn Island that I showed, all you've got there is one GP on that island, and there's really no way of getting off. To get off, there's a boat once a month, 3 days to Mangareva, 4-hour flight to Papeete, and then another 5-hour flight to Auckland. It's pretty hard to follow them up, except for what the GP can say.
Dr. Hayden, here Aravind has a model, and we emulated some of it in Singapore as well, where you actually employ a local person, train them, and they are the ones who do the counseling, they are the ones who take the photos, and then they send it electronically, so the patient doesn't have to travel. So if you could have that kind of a machinery that is locally available and trained, that would be great.
Yes, that's what we think should be the case.
And not involving the trained nurses, but maybe you could tap on the optometrists or even the local educated people whom you can train. They need not be healthcare workers.
Yeah, you're talking about islands that may have a population of, a few hundred or a couple of thousand.
Yeah. I had one question for Dr. Vignesh. You said there's something, there are two types, fiber and non-fiber iris implant, number one. And the first one you didn't suture. So does it not displace when you don't suture it? And when do you decide whether you're going to take the fiber or a non-fiber implant?
If I'm planning to place it in the bag or in the sulcus, you use the fiber-free version. So the fiber-free version sits inside the bag or on top of the existing bag in the sulcus.
And why do you prefer that? I'm sorry, I didn't get the difference between the fiber and the non-fiber.
The fiber one is quite rigid, so you can pass sutures through it and it doesn't cheese wire. So then you can use that for scleral fixation, to the sclera. The fiber-free one is more softer, can be foldable. You can fold it, inject it through the injector like I showed you in the video, and it can just stay in the sulcus.
So what is our experience of the panelists who have used the Mosher lens compared to maybe this new modality? Is there any advantages of one over the other?
No, the standard, I used to use the Mosher lens before, the big one with the black, the black diaphragm. But then when one eye is brown or the other eye is black, or, it is, of course, cosmetically. And second thing is that the aperture is quite big on the Mosher lens as well. So it still has a significant amount of glare. Thank you.
I just wanted to mention that in 2 weeks' time, we've got establishing task forces specific to address this problem of screening follow-up and the whole journey. So, there's a tsunami of diabetes in the Pacific, and it is a serious problem. So, lots is happening better later than ever.
I just had a question about the adalimumab, the drug. In Bangladesh, tuberculosis is very high, and a lot of people are exposed, maybe not known, and latent TB is also very high. So I just wanted to ask, what are the investigations I should go for in such a difficult case of uveitis where I can't, and I want to reduce the steroid dosage? Will MT and HRCT be enough, or do I need to go for the quantiferin TB gold test? And another is that what are the tests that I should do, like liver function test, subsequently while I'm giving this drug?
I'll answer the easy question first. The tests that you need to do are pretty minimal. We usually do a full blood count and a biochemical panel twice a year because these drugs rarely cause any significant hepatic, renal, or bone marrow toxicity. It's a much harder question sorting out TB. In a non-endemic area where I work, we would just do a quantiferon and a chest x-ray. In an endemic region like yours, where TB is very common, probably a high-resolution CT, if you can, and a quantiferon and or a MAN2 are probably the best ways to find out the at-risk population. The challenge that you have is using a biologic in a TB endemic area means that basically anybody who you can show has latent TB needs to be treated, because if you don't, you will unmask their latent TB with a biologic, unfortunately, and that's a huge burden. Yeah.
I have a question for you. I'm not a uveitis specialist, but just as inquisitive, whether you would consider starting immunosuppressants first before switching to biologics, or is there any rationale in which case you would choose what?
Yeah. So at the moment, our normal practice is that we would start someone on steroids to get the inflammation under control. And if it's a disease that we know is going to need long-term treatment, we'll start methotrexate. Methotrexate is as good as any of the other drugs. We all know how to use it, and it's very affordable. Then the decision point is really if you can't control it on that regimen. And conventionally what we would do is just either change the second line drug to mycophenolate or azathioprine or cyclosporin, or we'd use a combination of the two drugs. But now with these biologics, the option is to change or add in a biologic rather than a second conventional drug. And there's a very large randomized controlled clinical trial which should be fully enrolled within the next 6 months that's going to answer that very question as to what is the better alternative. Everyone's gut feel is that going to the biologic will be the way to go, but we haven't got the data yet.
Thank you.
I have one question for Dr. Verma. Dr. Verma, what do you think might be the low-lying fruits for immediate sustainability initiatives that all of us could take?
Is the ability to question the industry as to why they do what they do. I think that's the first thing that we as a group do. The evidence doesn't show that what they're doing in terms of packaging and all that is really necessary. So I would start questioning rather than simply accepting what is given to us. I honestly think that's the way to go, because it doesn't matter what else you do, you get something that's packed in plastic. The other thing, of course, is to start working within the organizations to really ask how we get our packs. Do you need 6 things individually packed, or can all of them come in a combined pack? So on. You have to question what we do, and you have to take time off to question what we do.
Thank you very much. And I would like to thank all the speakers as well as the audience here for the questions. If there are no further questions, then we'll end this session. This is the last session of the day. And thank you very much.